Good afternoon, everyone. I'm going to present you the 6-month progress of my PhD, which focuses on contemporary alignment techniques in total knee arthroplasty. I'm a third-year resident in trauma and orthopedic surgery and a first-year PhD student from Székesfehérvár. I'm interested in the treatment and management of osteoarthritis, and I have a special interest in total joint replacements. During my PhD, I'd like to compare two techniques in total knee arthroplasty, kinematic and mechanical alignment. My first project is a systematic review and meta-analysis, and my second project is a randomized controlled trial. In my first project, I'd like to compare the safety and effectiveness of kinematic and mechanical alignment in total knee arthroplasty in a systematic review and meta-analysis. So knee osteoarthritis affects over 300 million people worldwide, and the gold standard treatment for painful advanced knee osteoarthritis is total knee replacement. In the US alone, about 800,000 operations are carried out every year, and we have a problem. And the problem is that 1 in 5 patients are not very satisfied after the operation. And another problem is that we don't really know why, the exact reason why. And according to one theory, the problem is related to the alignment of the implant. So alignment means it's the relationship of the implant to the axis of the bone. And as you can see, there are different shaped legs. Someone has got a bowed leg, someone's got a bit crossed leg, someone's got straight leg. And we've been using the mechanical alignment since the 80s, which is a safe, easily reproducible, and relatively successful operation. The problem is it disregards the individual variability. And therefore, other approaches were developed, such as the kinematic alignment, which try to take into consideration anatomical variations and especially collateral ligament tensions and soft tissue relationship. So the aim is we would like to identify the optimal alignment technique in total knee replacements. I'm not going to spend much time on this slide, but as you can see in one corner, this slide sums up my PhD topic in one slide. In one corner, mechanical alignment aims for a perpendicular axis on the mechanical axis, and in the other corner, kinematic alignment completely disregards this axis, and it only takes into account individual anatomy. My clinical question: does kinematic alignment lead to better clinical outcomes compared to mechanical alignment, since it's a more personalized approach? This can be measured in various outcomes, such as pain relief. We mostly want to give patients pain relief. We also want to improve mobility. We want fast rehabilitation as fast as possible. We would like to improve patient satisfaction and decrease the morbidity associated with the surgery. And our hypothesis is that kinematic alignment performs better, at least in some of these outcomes. We conducted a systematic search in 3 databases, and we got, after duplicate removal, we got over 2,000 results and 18 eligible full texts. I've completed the data extraction, and we started the data analysis, and I'm going to present you the results that I've got so far. So on this slide, we've got the Oxford knee score, 2 years after the operation. Oxford knee score is a patient-reported measure for function and pain, and from 0 to 48, with higher scores representing better results. In my meta-analysis, we only included randomized controlled trials, and in this category, there were 7 studies with a total of 600 patients, and we can see that the total effect was 0.5, which is clinically not very relevant, and it doesn't reach statistical significance. And as you can see, we also have an outlier, which probably explains the high heterogeneity in the study. That outlier was one of the earliest studies. It's also in a US private institution. Most studies are in state institutions, so there can be various factors leading to the study being an outlier. My second result is the forgotten joint score 2 years after the operation. And this is a patient-reported outcome regarding how much the patient is aware that they had an operation. It is a measure of the success of the operation. The less the patient remembers and is aware that they had an operation, the more successful the procedure. It's on a scale of 0 to 100. and with higher values representing better results. And we had 4 studies, 4 RCTs in this analysis with a total of 400 patients. And we can see that there is a moderate clinically relevant total effect in favor of the kinematic alignment, and it reaches statistical significance. And either though the clinical result is moderate, it does align with our theory that kinematic alignment respects the individual anatomy and doesn't disturb the natural need proprioception as much as the mechanical alignment. So it's an interesting result. And another result is flexion degree 2 years after the operation. So flexion is a measure of the mobility of the knee, the range of motion. And the natural healthy knee flexion is between 0 degrees, which is complete extension, and 150 degrees, which is complete flexion. After total knee replacements, we aim for at least 90 degrees so that when the patient can sit down, you know, they can flex their knees. So anything above 90 degrees is acceptable, and the higher the value, the better. We can see that the total effect was 4.5 degrees, which doesn't reach statistical significance. But when we do a subgroup analysis, looking at unrestricted and restricted kinematic alignment, 2 subgroups, we can see that the unrestricted group actually has a higher total effect, which is about 67 degrees, and it does reach statistical significance. So this we can call clinically relevant. An extra 7 degrees of flexion is valuable improvement. So without having completed all the results, I don't want to go for far-reaching conclusions, but we can say that there can be potential mobility benefits with the kinematic alignment approach for people with knee osteoarthritis. And however, functional outcomes are similar for the 2 techniques at 2 years postoperatively. Both techniques can be used for knee osteoarthritis in everyday practice, and we probably need more randomized controlled trials comparing restricted and unrestricted kinematic alignment together. This is a summary of my first project. I've reached the data analysis stage, and the next stage will be the risk of bias analysis. My second project is comparing inverse kinematic alignment with mechanical alignment in a randomized controlled trial. As I've discussed, there's been a shift towards more personalized techniques in total knee replacements. And there's also a rise with the use of robotic assisted technologies and enabling technologies. Since 2017, we saw a rise from 2% to 16% in the US. And with these robotic and improved technologies, we can use other personalized approaches and variations of kinematic alignment, such as the inverse kinematic alignment, which is a relatively new technique described in 2020. There hasn't been a direct comparison of mechanical alignment and inverse kinematic alignment. So we would like to compare these 2 techniques directly. And essentially, we're looking at the same things, and our hypothesis is that inverse kinematic alignment, because it's a personalized approach, leads to improved clinical outcomes compared to the traditional mechanical alignment. In summary, I have 2 projects comparing kinematic and mechanical alignment in total knee replacements. And my first project is a systematic review and meta-analysis. My second project is a randomized controlled trial. Thank you very much for your attention.
Thank you for the presentation, and now the questions.
So thank you for your presentation. It was very interesting. My question is for the patients that do have this kinematic alignment and they still have complaints afterwards, what are methods that you can apply to relieve their pain or kind of comfort them and help?
Yeah, a bit of both, yes. So we first have to identify the cause of the pain. We first need to rule out complications such as infection because a lot of times residual symptoms can be explained by complications such as infection after the operation. If we rule out those, we could, if the symptoms are severe enough, we might consider revision surgery, and there are various ways of redoing the surgery. But I guess the way of doing it is wait and see. Wait if the symptoms improve, and if they don't improve and they disturb the patient's life, then do a revision surgery.
I would like to ask that you mentioned restricted and non-restricted kinematic alignment. What's the difference between those two?
Yeah, thank you for the great question. Kinematic alignment started with being the unrestricted kinematic alignment. If you may remember one of my slides, which shows that it completely disregards the mechanical alignment, and it only takes into account ligament tensions and individual anatomy. However, there were concerns at the beginning with this approach, with early loosening of the implant, because forces acting on the implant may be not equal in extreme deformities. So some people came up with certain safe zone parameters which they don't exceed, and they called it the restricted kinematic alignment, in which they hope that by staying in the safe zones, they will not increase the risk of early loosening of the implant with time.
I would like to ask you if are you considering doing a network meta-analysis? Because I know you have only RCT, so maybe that could be an option.
Absolutely, yes. We've discussed this option with the statisticians, and it seems that we can do network analysis comparing unrestricted, restricted, and mechanical alignment together.
Congratulations on your presentation. My question would be that you mentioned that you would like to analyze the limb alignment,
yeah.
And how do the different techniques, so the mechanical and the kinetical alignment, impact differently on the limb alignment?
Yeah, thank you. So in mechanical alignment, by having the implant in the mechanical axis of the limb, we actually correct for the overall deformity of the limb. So most patients after the operation get a straight limb, regardless of the deformity they had. With kinematic alignment, this correction is, we don't do this correction, so they still get some, deformity in the leg, but it's not going to be, straight. So.
Mm-hmm. Okay, I see. Thank you.